Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Margot Klemmer, an anesthesiologist and intensivist practicing in Winnipeg, Manitoba, discusses the management of traumatic brain injuries in the perioperative setting. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Thank you again for the invitation to speak with you this morning. As a proud USask alumnus, I'm just delighted to be able to speak with the department today. I do want to preface my talk by saying that I feel like a bit of a fraud each time I speak on this topic. I'm not an expert in traumatic brain injury, but I am a clinician with an interest in the area, and as so many good learning experiences, it was motivated by fear of doing the wrong thing for my patients in the ICU. And I do want to acknowledge as well that I am a fairly junior clinician. I have a fraction of the experience of many people in the audience today, and I'm deeply humbled that I have the opportunity to present to you. This lecture is not designed really for practicing intensivists or to discuss focused care of patients in the ICU, but it's intended as a little refresher on managing critically ill patients with traumatic brain injury in the operating room or post-anesthesia care unit. It's a slightly modified version of a presentation that I gave at the Canadian Anesthesia Society conference last summer. I have nothing to disclose with respect to conflicts of interest. As a faculty of the University of Manitoba, I do want to take a moment to acknowledge that I am presenting from the traditional homelands of the Anishinaabe, Cree, and Oji-Cree, Dakota, and Dene peoples, as well as the homeland of the Métis Nation. Our department is motivated and making active strides towards acknowledging the harms of our history in Canada and dedicating ourselves to moving forward in partnership with Indigenous communities in Manitoba. More than a random walk through essential ICU topics, my aim this morning is to explore some elements of the perioperative care for a complex, critically ill patient population, one that we often encounter in the operating room, and hopefully to provide some insights as to how we as anesthesiologists can contribute to or mitigate harm for brain injured patients coming to the operating room. We're going to focus a bit on ventilation strategies, blood pressure targets, and ICP monitoring and therapies, as well as a brief discussion of some evolving concepts in cerebral monitoring, particularly of cerebral autoregulation. I'd like to warm us up with a bit of a case. So consider that of a 37-year-old patient brought in by STARS to the emergency department following a highway speed single vehicle rollover. He was the unrestrained driver and found 20 meters from the vehicle. On the scene, he was unresponsive to voice or pain and had no observed movement in any of his extremities. He was intubated with appropriate spine precautions for transport to your hospital. He was hemodynamically unstable during transport and received 2 units of red cells prior to hospital arrival. In the emergency room, he becomes progressively hypoxemic, but this improves after insertion of bilateral chest tubes. His blood pressure normalizes transiently with additional red blood cell transfusion, and during a period of relative stability, his best neurologic exam demonstrates flexion of the right arm to pain with no eye opening. As they're preparing for a CT, he again becomes critically unstable with systolic blood pressures falling into the 60s and 70s. His fast exam is now positive for fluid in the abdomen. There's no suggestion of pericardial tamponade or massive hemothorax. You're now taking him directly to the operating room for exploratory laparotomy and control of hemorrhage, as he's too unstable to undertake imaging. Unfortunately, I don't have polling integrated into the lecture today, so I'd just like you to take a moment to consider whether or not this statement resonates true for your own practice, that the presence of a potentially severe TBI is high in your considerations for this patient. Ultimately, I have to thank the 6th year U of M residents this year and last year for inspiring me to revisit this topic, because as we went through our exam preparation, both this year and last, When presented with a similar scenario, interventions to support potentially very severe brain injury were frequently overlooked components of management for this case. And it occurred to me that if this was true of our fifth-year residents, and it was probably true of many of the faculty in my department, as well as of my own practice, and I wanted to address some of those deficits. So looking back at our patient, his exam in the emergency department combined with the mechanism of injury is highly concerning for severe traumatic brain injury. But given that he remained unstable in the emergency department, we can't actually say how severe his intracranial injury might be. The consensus definition of traumatic brain injury is an alteration in brain function or other evidence of brain pathology caused by an external force. That altered function may present as loss of or decrease in level of consciousness, memory loss, or neurologic deficits at the time of injury. Although there may be confounding factors at play in a polytrauma patient, like intoxication precipitating an accident, impaired neurologic status should never be ascribed to confounding factors until serious neurologic insult can be ruled out. In this scenario, we can't rule out the presence of severe traumatic brain injury prior to going to the operating room, and we should engage with this patient with the goals of preventing secondary neurologic injury. Traumatic brain injury is still a very heterogeneous group of pathologies. It affects all populations and spares no ages. It's a major cause of death and disability globally, with an estimated 69 million new cases occurring annually around the globe. Falls and traffic accidents account for the majority of traumatic brain injury in the civilian population, and fall injuries as a cause of TBI are on the rise among older adults in high-income countries, and certainly a population with which we interact frequently. About 10% of head injuries presenting to the emergency department are severe, and those cases have roughly 30% in-hospital mortality. Both moderate and severe TBI present major social and health-related challenges long-term, but outcomes are not as uniformly poor for severe traumatic brain injury as is often perceived. Recovery is slow, sometimes even continuing beyond 12 months after the injury, but as many as 1 in 5 severe traumatic brain injury patients reports no disability by 12 months post-injury. From the TRACK TBI study, we know that at 2 weeks post-injury, the level of disability is quite high. About 12.4% of severe TBI patients at 2 weeks have favorable outcomes. But by 12 months post-injury, that number increases to just over half of severe TBI patients having achieved a favorable outcome, which is defined as the ability to function independently at home for more than 8 hours a day. Among participants in a vegetative state at 2 weeks post-injury, about 78% to 80% will regain consciousness, and 25% will regain orientation by 12 months. That may be a very high burden of disability and may be unacceptable to some patients or their families, but it's certainly better survival and more reasonable quality of life than is often thought of. As an intensivist, I spend a good portion of my time thinking about how we move more patients into the favorable outcome category. In particular, how can we help more patients to achieve limited or no disability? Now, there isn't a silver bullet for improving outcomes in TBI or any other critically ill condition, but if we improve our systems of care for these patients from pre-hospital to the neuro rehab unit, we might ultimately be able to move the needle on neurologic recovery. Guidelines, for all of their acknowledged limitations as part of our clinical practice, are a part of strengthening those systems of care. Although the quality of evidence underpinning many recommendations and the numerous guidelines we have for traumatic brain injury management is low or moderate quality, we do know that implementation of guidelines, in particular the Brain Trauma Foundation guidelines and the civic TBI management algorithms, can improve outcomes and survival for severely brain injured patients. If you'll forgive me, I have a gross oversimplification of traumatic brain injury pathophysiology on this slide here. When we talk about primary injury, we're referring to the immediate parenchymal damage that occurs during trauma and sets in motion a cascade of inflammatory changes that contribute to secondary injury. Additionally, there are systemic factors within our control at the bedside that perpetuate further secondary injury. The critical care and perioperative management of traumatic brain injury patients aims to reduce the occurrence and burden of these secondary insults, such as those caused by hypotension, hypoxemia, and intracranial hypertension. Management of TBI begins at the time of injury. We need to recognize and respond to the presence of TBI early in their hospital course, and even especially in their pre-hospital care. These principles apply whether or not a patient is coming for damage control surgery immediately following injury, or delayed fixation of a fracture, or decompressive craniectomy for control of refractory hypertension, intracranial hypertension. TBI management guidelines are aimed at two basic concepts. That's restoring cerebral homeostasis and prevention of secondary injury. The principles listed on this slide are familiar to all of us as the core management of a tight brain for intracranial surgery, and they're equally fundamental to the management of severe TBI, regardless of intracranial pressure. These form the foundation or tier 0 management of a tiered approach to the management of TBI patients. These interventions can be easily undertaken for all polytrauma patients with potentially severe TBI in the operating room. Whether it's for emergent intracranial surgery or extracranial surgery, neurologically targeted interventions should always coincide with a relentless hemodynamic and pulmonary resuscitation, because we know that hypotension and hypoxemia are the major modifiable systemic insults associated with secondary brain injury and worse outcomes for the TBI population. With respect to respiratory care, we know that mechanical ventilation will play a foundational role in mitigating secondary injury, given the deleterious effects of hypoxemia on cerebral ischemia and of hypercapnia on intracranial hypertension. Targeting a PaCO2 in the normal range of 35 to 45 is consistent across most guidelines for traumatic brain injury management. A systematic review from 2021 confirmed that early mortality benefit from targeting from targeting normocapnia, but didn't evaluate a specific ventilation strategy. We know that there is no benefit and possibly harm associated with prophylactic hyperventilation, and any use of lower CO2 targets other than to prevent impending herniation should be accompanied by monitoring of brain tissue oxygenation. Continuous capnography is a good surrogate for our PaCO2 when we have quantified our dead space. This can be done by comparison to arterial blood gases and should be reassessed with any changes in ventilator settings. Polytrauma patients we know are more likely to have heterogeneous ventilation and increased dead space in the setting of concurrent chest trauma, hypotension, and metabolic derangements. There are currently no recommendations within the Brain Trauma Foundation guidelines as to the management of ventilation to achieve these stated CO2 goals. But the European Society of Intensive Care Medicine last year had stepped in to fill some of those gaps. In severe TBI patients, who we know are vulnerable to lung injury secondary to a combination of direct chest or pulmonary injury, as well as to neurocardiogenic pulmonary edema, as well as further insult from systemic inflammation in response to trauma, we should be taking steps to mitigate further ventilator-mediated injury. And as such, the recommendation of the European Society of Intensive Care Medicine is to employ a ventilator-induced a lung protective ventilation strategy employing low tidal volumes, moderate to high PEEP, and targeting plateau pressures of less than 25 to 30. These targets are rational based on the propensity of this population towards lung injury, but not directly supported by evidence in this population. The majority of recommendations made by the ESICM are on the basis of biologic plausibility rather than direct evidence. They also favor the use of individualized PEEP in this population. When possible, the relationship between PEEP and ICP should always be evaluated on an individual patient level. Many patients with severe TBI are PEEP or relatively PEEP insensitive with respect to their intracranial pressure, but those with the most severe derangements in their ICP at baseline may experience more dramatic elevations in intracranial pressure in parallel with PEEP-related increases in intrathoracic pressure. Important to take away from this is that the use of PEEP is not contraindicated in the head injured patient. And again, although routine hyperventilation is not recommended, it is a strategy for preventing imminent death related to imminent herniation. As in non-traumatic states of brain injury, like stroke and post-cardiac arrest, there's mounting evidence of the harms of hyperoxia in the recovery of brain trauma. ESICM now recommends maintaining a PaO2 between 80 and 120 to avoid the harms of hypoxemia on cerebral ischemia, as well as hyperoxia on cellular recovery. A 2023 analysis of the Center TBI and AusEnter TBI cohorts, which are two multi-center prospective observational cohorts of moderate and severe TBI patients in Europe and Australia, demonstrated a higher 6-month mortality in patients exposed to higher daily PaO2 in the first week post-injury. So then what about blood pressure? Hypotension driving cerebral ischemia is arguably the most important cause of injury in TBI and has a major effect on early mortality. You know that cerebral blood flow is most critically impaired and autoregulation is the most abnormal within the first 3 days post-injury. It's in this phase that we're most likely to see pressure passive cerebral blood flow with worsening ischemia at lower blood pressures and hyperemia at higher blood pressures. Even with intact autoregulation, hypotension remains dangerous in this phase, as a decrement in blood pressure is accompanied by cerebral vasodilation and increased cerebral blood flow, potentially provoking a rise in intracranial pressure and the setting of a vasodilatory cascade that can be difficult to break. As we see here, a target blood pressure of 90, a systolic blood pressure of 90, in keeping with permissive hypotension during damage control type surgeries, is really not appropriate in a severely head injured patient, given the considerable increase in mortality at that pressure. For each decrement below a systolic blood pressure of 120, the risk of death in TBI patients increases quite dramatically. Now, the association between hypotension and death in TBI has been known for decades, but newer large cohort studies from the 2010s, like this one from the Trauma Audit Research Network, have been influential in setting thresholds for systolic blood pressure in more recent TBI guidelines. Less discussed but equally important is recognizing the harm associated with hypertension and cerebral hyperemia, resulting in greater edema formation for the injured brain. As the data on this slide illustrate, mortality in severe TBI increases at both extremes of blood pressure. In the early resuscitative phase, when ICP monitoring is not available to us, the Brain Trauma Foundation recommends an age-stratified systolic blood pressure target of greater than 100 for patients between 50 and 70 years of age, and greater than 110 for patients from the age of 15 to 50 or over the age of 70. In the presence of an ICP monitor, as may be the case for patients undergoing delayed extracranial surgery, a CPP target is recommended instead, with the recommended range of 60 to 70. Data supporting this recommendation comes primarily from one large retrospective cohort study, but given the clear association between hypotension and worse outcomes, it's unlikely we'll ever see larger or more comprehensive trials directly evaluating blood pressure targets in severe TBI. Brain injured patients are prone to cardiovascular dysfunction, and this dysfunction may be present on arrival to the hospital or evolve over the early days of their admission, and it can encompass a range of pathologies, including neurogenic stress cardiomyopathy, which may manifest as global dysfunction or isolated left ventricular dysfunction, dysrhythmias, subendocardial ischemia, and paroxysmal sympathetic hyperactivity. Transthoracic and transesophageal echo can be immensely helpful in evaluating the many possible reasons for intraoperative hypotension in the head injured polytrauma patient. Crucial to remember that not all shock is bleeding in this population. Reach for the echo probe to assist your resuscitation. So now that we understand the importance of reaching a specific blood pressure threshold in the TBI population, the natural question is there evidence to support one particular intervention over another in order to meet those goals? Well, in short, the answer is no. During resuscitation, like for our patient undergoing damage control surgery, the choice of fluids or vasopressors to support or meet blood pressure targets will depend on the clinical scenario and our ability to determine and treat the processes driving hypotension acutely. For the polytrauma patient with hemorrhagic shock, there's a role for both intravascular fluid resuscitation as well as vasoactive agents. The Brain Trauma Foundation guidelines support balanced transfusion and early tranexamic acid administration for traumatic hemorrhage. Our transfusion targets for the head injured patient are essentially the same as for any major hemorrhage patient outside of the obstetrical population. And there isn't definitive evidence of targeting a higher platelet threshold in this group. Minimization of crystalloid to minimize trauma-associated coagulopathy, and minimizing the administration of albumin should also be considered. That's based on subgroup analysis of the SAFE study, which demonstrated higher mortality and mean intracranial pressure in patients who received 4% albumin. Important to emphasize too that the avoidance of iatrogenic hyponatremia associated with crystalloid administration is crucial in this population as well. But that goal can often be met with either balanced crystalloid or saline. Although the use of vasoactive medications to achieve a systolic or NAP target with the goal of defending a cerebral perfusion pressure between 60 and 70 has become a mainstay of severe TBI management, there's no high-level evidence to support this practice. A 2020 systematic review of the use of norepinephrine to achieve CPP target ultimately concluded that there's no improvement in mortality or neurologic outcome associated with vasopressor use specifically, which is not surprising. But used in conjunction with other neuroprotective strategies, vasopressor use to meet a modest CPP target, as advocated for by the Brain Trauma Foundation guidelines, does appear to be safe. Where we need to be more concerned is when we start seeing a push to achieve a CPP above 70, because we know that this increases the risk of pulmonary edema and myocardial injury in this population. The bottom line is that both fluids and vasopressors are likely needed during the resuscitation of a head injured trauma patient, and both should be used as needed and titrated to effect with frequent reassessment of the indication for each. I want to caution us against both overzealous fluid administration, where we know there's harm to the general critical ill population with increasing fluid positivity, and to excessive vasopressor administration, which potentially risks exacerbating ischemia in regions of disturbed autoregulation or worsening lung injury or myocardial injury in this population. Finally, patients with severe traumatic brain injury admitted to the operating room directly from the emergency department following polytrauma are unlikely to have received seizure prophylaxis as part of their initial resuscitation. The initiation of prophylaxis in the operating room can be done as part of our TBI management, the aim of reducing the incidence of post-traumatic seizures. Both Keppra and Dilantin may be used for this purpose, and Keppra is gradually replacing phenytoin as the preferred agent. There isn't really a well-studied optimized dose of levetiracetam for this purpose, but a reasonable and common dosing strategy is a loading dose of 20 milligrams per kilogram over 5 to 15 minutes, followed by 1 gram twice a day. If using phenytoin or Dilantin, 15 milligrams per kilogram, followed by 100 milligrams TID, adjusted to therapeutic drug monitoring is the common dosing strategy. Let's take another look at our patient. During this initial operation, he undergoes splenectomy and a small bowel resection for control of hemorrhage. An X-fix is placed on an unstable pelvic fracture, and he goes from the operating room directly to the CT or radiology department for the rest of his traumagram. The CT brain shows frontal contusions, small interparenchymal hemorrhages scattered throughout, and a small amount of subarachnoid blood, but no large subdural or extradural hematomas requiring evacuation. An intraparenchymal ICP monitor is placed in the ICU, and he moves into the next phase of his post-trauma management. It seems so many things in medicine these days are referred to as multimodal in contemporary practice, and monitoring in TBI is no different. And for the remainder of the session, I'd like to discuss a few elements of monitoring that we might encounter in the operating room for TBI patients undergoing either intracranial or extracranial surgery following a period of stabilization. As these monitors are often unavailable in the acute phase, it's important to be familiar with their use and the information that they may provide us, but also appreciate that we may be faced with decision-making in the absence of this information. So ICP is the most commonly measured cerebral physiologic parameter in the TBI population. And intracranial hypertension is an independent predictor of mortality and poor outcome. Pathologic intracranial hypertension is defined as any pressure greater than or equal to 20 millimeters of mercury, and targeting a goal of an ICP less than or equal to 22 is recommended for more favorable outcomes by the Brain Trauma Foundation in TBI patients. However, we know that the pathophysiology of TBI includes much more than just intracranial overpressure, and although avoiding ischemic and mechanical damage from elevated ICP is mandatory, lowering ICP alone does not treat the primary injury or necessarily prevent other forms of secondary injury. The type of injury resulting from intracranial hypertension is also not just a matter of crossing a threshold. We should be thinking of burden of ICP or ICP dose as the mediator of secondary injury in this population. the combination of intensity and duration of episodes of intracranial hypertension have a stronger association with outcome than discrete brief elevations alone. Spending more time with an ICP in the range of 18 to 22 increases disability and mortality following TBI, compared with patients who spend more time with an ICP of less than 18, even though patients in these two groups may have similar therapeutic intensity or similar interventions received for ICP control. One of the questions that frequently crossed my mind before I was more familiar with this literature was who really needs intracranial pressure monitoring, especially patients coming to the OR. And the Brain Trauma Foundation provides the strongest guidance about who requires placement of an ICP monitor. And they advocate that any patient who remains comatose after resuscitation with a GCS of between 3 and 8 and has either an abnormal CT scan or a normal CT scan, but other risk factors, namely age over 40, a systolic blood pressure of less than 90, or abnormal posturing, should receive continuous ICP monitoring. In addition, ICP monitoring is indicated when there's clinical suspicion of intracranial hypertension. We'll talk a bit more about that in the next slide, as well as when patients have a GCS that is rapidly declining, or in patients who have moderate TBI, but not a followable neurologic exam due to sedation requirements. And that would be potentially a population of interest to us in the operating room, as they may be at risk for worsening brain injury and secondary insults, but no longer have a followable neurologic exam. So during resuscitation, as we saw in the first part of our case, we often don't have access to invasive intracranial pressure data to indicate when or if we should implement more than basic measures to treat intracranial hypertension. But we should be comfortable with assessing every polytrauma patient with a potential closed head injury for signs and symptoms of elevated ICP. In particular, their overall level of consciousness and the best score in each element of the Glasgow Coma Scale, with particular attention to the motor score, as well as pupillary assessment, can provide a lot of insight into their risk of having an ICP above that critical threshold of 22. Obviously, I think we're all familiar and worried with the manifestation of critical intracranial hypertension as seen in Cushing's triad with a widened pulse pressure, bradycardia, and irregular breathing, and should be familiar with steps that can be taken immediately to avoid imminent herniation. There's been a lot of discussion about whether continuous ICP monitoring versus empiric therapy for suspected intracranial hypertension actually improves neurologic outcomes. And this is motivated by a trial in a Latin American cohort. The trial is known as BEST TRIP, that compared invasive monitoring to clinical and radiologic exam to guide ICP therapies and found no difference in outcomes for the patients in those cohorts. The clinical scale and the decision rule that was used as a part of this study is illustrated on the slide here. And in the absence of imaging, we're reduced to evaluating the minor criteria, which are still incredibly helpful, which abnormalities in 2 or more of the clinical criteria predicts the likelihood of an ICP above 22 with a sensitivity of 94% and a negative predictive value of 90%. So patients who don't meet these criteria when we're seeing them in the emergency room or in the operating room are unlikely to have an ICP above 22 and unlikely to benefit from therapies directed at reduction of their ICP acutely. One other tool at our disposal at the bedside is yet another application of point-of-care ultrasound. Both transcranial Doppler and optic nerve sheath diameter measurements have been used to estimate ICP non-invasively. Transcranial Doppler has many applications in neurocritical care, but the learning curve is steep and the measurements have less direct application to ICP estimation. Whereas optic nerve sheath diameter has much more utility at the bedside and is something that's often readily accessible to us in the operating room. The optic nerve sheath is part of the continuous dura enveloping the cerebrum and communicates directly with our CSF. So changes in ICP are reflected directly in changes in optic nerve sheath diameter. This is essentially the modern papilledema test. Studies have found good correlation between ultrasound measurement of optic nerve sheath diameter and both radiologic scoring systems and direct ICP measurements, and fairly good inter and intra-observer reliability. When applied to patients with traumatic brain injury, an optic nerve sheath diameter of greater than 5 millimeters has a 97% sensitivity and 86% specificity for an ICP above 20, which is actually similar to the reliability of our direct ICP monitors. The technique for measurement of our optic nerve sheath diameter is illustrated here. I apologize if it doesn't appear particularly clear on your screens, but the nerve sheath diameter is meant to be measured 3 millimeters behind the retina and is defined as the distance inside the dura mater, which is defined by the hyperechoic area surrounding the optic nerve. The distance inside the pia is the optic nerve diameter, and it's inside those more hyperechoic shadow areas. In a pinch, this can be useful in estimating ICPs above 20 or 22 in patients who might require more acute interventions. But again, as with many ultrasound-based techniques, there is a learning curve to implementing this, and it would require practice before being confident to use it as your sole therapeutic, test to guide therapy. So naturally, if we're going to monitor intracranial pressure, we should likely have a set of interventions for correcting critical elevations in it at our disposal. Most importantly, we need to remember that any rise or suspected rise in ICP intraoperatively should prompt a search for the cause in parallel with efforts to bring that pressure down. Common possible causes that should be top of mind include new or expanding intracranial lesions, sudden increases in intrathoracic pressure, like pneumothorax, hemothorax, bronchospasm, coughing, or other causes of ventilator patient dyssynchrony, and sudden increases in intra-abdominal pressure, such as retractors or packs, as well as inadequate venous drainage coming from evolving tamponade, rotation of the head, pressure from the cervical collar, change in operative position, or change in bed position. And those factors should all be sought out and corrected rapidly in patients who either demonstrate a measurable increase in their ICP or for whom we're significantly concerned that there's been a change. So the most popular ways to address intracranial pressure elevation beyond those basic interventions in the prior slide are hyperosmolar solutions of saline or mannitol. They work essentially by dehydrating the brain parenchyma. There's long-standing debate as to which is the superior agent, though this has been largely laid to rest in the past 5 years. The short answer is that neither is superior. Equiosmolar concentrations of 20% mannitol or 3% saline will have a similar effect on reducing ICP. Hypertonic saline has become generally favored, especially in the ICU setting, as it's faster onset, easier to administer, has a shorter infusion time, doesn't require special filters, and is associated with less hypotension. Ultimately, the choice is left to the individual using it. And comfort with either option is something that we should all seek to build. Of course, our anesthetic agents might also be of use in modulating ICP responses. We should always be seeking to ensure we've achieved an appropriate depth of anesthesia or analgesia relative to the surgical stimulation, and can consider acutely deepening our anesthetic to drive down CMRO2 in order to reduce oxygen consumption, cerebral blood flow, and ICP. Neuromuscular blockade to address dyssynchrony is also extremely valuable in patients who have a demonstrable response to neuromuscular blockade in terms of reducing their ICP. Finally, for patients who have an EVD in place, it's obviously a very effective means of bringing down ICP over a longer period of time. It's increasingly common to practice continuous drainage with intermittent ICP monitoring rather than continuous monitoring with intermittent drainage, as this is associated with better overall control of ICP. For anyone needing a refresher in the use or management of an EVD, they can visit the Society of Neuroanesthesia and Critical Care.org for an excellent video on how to set up and use an EVD intraoperatively. So moving into the final bit of our time together, I want to talk a bit about some evolving concepts in monitoring traumatic brain injury. TBI care is in constant evolution, and depending on the nature of what's available in your practice, you might see a variety of advanced neuromonitoring techniques used in the care of severe TBI patients. One of my great frustrations in Winnipeg is that we do a lot of research in TBI, and there are many tools that are used in that context that aren't employed clinically and I don't have access to. One of the great interests in TBI monitoring right now is the concept of monitoring cerebral autoregulation. I think ultimately we would all like to have a bedside, non-invasive, rapidly responsive measure of cerebral blood flow rather than cerebral pressures or intracranial pressures. But what we're left with primarily is still pressure monitoring. We know that cerebral autoregulation is often altered, but not completely abolished in most severe TBI cases, and that it's most abnormal in the first 72 hours post-injury. Outside of the range of preserved autoregulation, the relationship between pressure and cerebral blood flow becomes massive. And this leads to increased risk of both ischemia when CPP drops below the lower limit of autoregulation and hyperemia/edema when CPP exceeds the upper limit of autoregulation. Continuous monitoring of cerebral autoregulation could provide a way to tailor our CPP targets to individual patients with the aim of improving neurologic outcomes as a result. These monitoring techniques will make a transition, I'm sure, from research to clinical use over hopefully a fairly short time course, and we'll be expected to start to incorporate their data into our practice. One of the most commonly used autoregulation indices is something called the pressure reactivity index, or PRX. It's a correlation coefficient between mean ICP and mean arterial pressure. It assumes that ICP strictly reflects changes in blood volume without compensatory pressure volume responses from the brain parenchyma or CSF, and is not applicable in patients who've had a decompressive herniectomy. This first slide illustrates where we would expect to find a negative PRX, as in normal autoregulatory responses, in a patient with normal autoregulatory physiology, being between cerebral perfusion pressures of 50 and 150. The second slide is an illustration of how that autoregulatory range might be altered in traumatic brain injury to a much narrower range of tolerated pressures, above or below which we may see deleterious changes in cerebral blood flow. One application of PRX, as I've talked about, is that optimized or individualized cerebral perfusion pressure target that corresponds with the lowest or most favorable pressure reactivity values for an individual patient. There have been retrospective studies demonstrating that deviations from this optimum CPP target are associated with worse outcome after TBI. And there is one larger prospective trial in progress to determine whether or not this truly does influence favorable outcomes. And so in the absence of the software to measure pressure reactivity dynamically, we do have one means at our disposal of exploring the autoregulatory state of the injured brain when ICP monitoring is available. This is something called a MAP challenge, and it might be particularly useful for us assessing changes in cerebrovascular reactivity for patients under general anesthesia coming back to the OR for either intracranial or extracranial surgery. The MAP challenge is done by titrating a vasopressor to increase mean arterial pressure by 10 for up to 20 minutes and observing the interaction between mean arterial pressure, ICP, and cerebral perfusion pressure during the challenge. Disrupted autoregulatory status will present as a sustained increase in ICP with MAP elevation, and strategies to lower ICP in these patients likely take precedence over strategies to augment mean arterial pressure or cerebral perfusion pressure, as is demonstrated in the figure on the right. With intact autoregulation, however, an increase in MAP can induce vasoconstriction with subsequent decrement in ICP. Higher cerebral perfusion pressure targets, those above 70, might be indicated in patients with this type of reactivity to assist in lowering ICP in specific circumstances, and may help to achieve a lower burden of increased intracranial pressure over a longer time period for those patients. These figures come from the 2019 Seattle International Severe Traumatic Brain Injury Consensus Conference, which I have to read every time, otherwise known as CIVIC, guidelines for intracranial pressure monitoring based management of severe TBI. But regardless of the results of a MAP challenge, our clinical judgment should still be rendered as to whether the benefit of ICP reduction outweighs the risks associated with pharmacologic augmentation of MAP, since we know that aggressive efforts to increase blood pressure in the setting of high ICP to achieve a predetermined CPP target can increase the risk of both hypoxic respiratory failure due to lung injury as well as myocardial injury. Finally, we know that systemic hypoxemia, as I've talked about, is associated with worse outcomes for patients with TBI through impaired oxygen delivery. But studies evaluating the occurrence of regional cerebral hypoxemia also demonstrate that low brain tissue oxygenation, or PbTO2 values, are associated with a higher mortality and detrimental effect. Again, like ICP, appears to be dose-related. When we use a threshold of less than 20 to define cerebral hypoxemia by brain tissue oxygen monitoring, we know that at least half of patients in the first few days post-injury with severe TBI will have episodes of cerebral hypoxemia, and that these episodes occur despite normal ICP or normal cerebral perfusion pressure. So interventions to address regional cerebral hypoxemia through reductions in CMRO2 or increasing oxygen delivery might contribute to improving outcomes post-TBI, but this benefit has not yet been demonstrated. Near-infrared spectrometry-based cerebral oximeters or parenchymal extracellular oxygen partial pressure monitors, the PbTO2, are most commonly used for monitoring regional cerebral oxygenation. Our Brain Trauma Foundation guidelines no longer include a target for PbTO2 in severe traumatic brain injury, but the Seattle TBI conference has a published tiered treatment algorithm for incorporating brain oxygen monitoring and ICP. There's no guidance for saying which values on our cerebral oximeters should be targeted or what interventions should be employed if we see negative trends in those values. But this remains a very active investigation area in TBI research, and I expect that in the coming 2 to 3 years, we will start to see more published evidence, hopefully in a favorable way, of how we can use these monitors and this information to target or tailor our therapies on an individual patient level and move the needle towards more favorable neurologic outcomes. So bring it on home. Just to remind us that neurologically targeted interventions must coincide with circulatory and pulmonary resuscitation to mitigate the secondary insults of systemic hypotension and hypoxemia, because they are still the areas where we have the most evidence of harm and the greatest potential to intervene. Targeting a PaO2 between 80 and 120 and normal capnia is advised. In the absence of an ICP monitor, we should aim to keep our systolic blood pressures above 110, or remember the age stratified targets. In the presence of an ICP monitor, targeting a cerebral perfusion pressure between 60 and 70, unless we have individualized data, is recommended. And finally, as this information becomes available for multimodal monitoring, consider its implementation in your own practice.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.